All right. Well, I see that we are at the top of the hour. So I say we get started. What do you say?
Sounds
All
great.
right. Good morning, good afternoon, everyone. On behalf of the FSHD Society, welcome to today's FSHD University webinar. Before we get started, just a quick reminder, this session will be recorded and it's going to be made available on our YouTube channel within the next week or so. We also encourage you all to use chat to interact with one another, but please, if you have questions for our presenter, use the Q&A function for questions. That's what I'll be monitoring to ask Dr. Rad at the end of the presentation today. So in today's webinar, you're going to learn about the role of the physiatrist from Dr. Nassim Rad. What's a physiatrist? I mean, this is new to me, honestly. I had to look it up. Physiatry is also known as Physical Medicine and Rehab, PM&R. It's a medical specialty that focuses on diagnosis, evaluation, and treatment of conditions that affect physical function and mobility. That seems to resonate with me. Dr. Rod is an assistant professor with the Department of Rehab Medicine. She serves as the Rehab Director. Um, I'm going to mispronounce this, of the Electrodiagnostic Lab and co-director of the Muscular Dystrophy Association Care Center at the University of Washington Med Center in Montlake, right? Is that a part of Washington?
It's actually just UW is so big that we have multiple hospitals, so it's our main hospital location.
Montlake is the name hospital location. Excellent. So,
Yeah,
and she's
no
also board
problem.
certified in neuromuscular medicine. So right now, welcome, Dr. Rod. I'd like to turn it over to you and we'll have
Thank
at
you
it.
so much. Thank you so much. I'm gonna start sharing some slides. Make sure that I do this correctly. Oh, okay. It wants to. Uh, okay, let's see if I.
This is always, oh, there we go.
Okay, it doesn't allow me to play it from the beginning until I'm in slide view. So do the slides take up the whole screen?
Now they do. You've got it.
Okay, so you see it just as a big PowerPoint. Wonderful. Well, thank you everyone for joining. This topic is obviously near and dear to my heart as a rehab medicine specialist. And again, as was already mentioned, physiatry goes by many different names. And I bet that some of you actually may know rehab doctors. And just had no idea they were rehab doctors. And so when we think about sports medicine doctors, so athletes or non-athletes who have had sports injuries, um, so anywhere from, all the way to neck down to ankle injuries, a lot of those physicians are rehab medicine physicians. A lot of pain physicians are rehab medicine physicians. A lot of physicians that work with spinal cord injury and traumatic brain injury patients are rehab physicians. And so I think that the unique nature of rehab medicine, or the what is rehab medicine, is really unknown when it comes to neuromuscular conditions because so many people think of just neurology. And so my goal today is to explain more about what rehab medicine does specifically for the management of FSHD. So, no disclosures here today, but basically, I want to start off by saying what has been identified as the, for lack of a better word, gold standard for how we should be managing FSHD. And if we pull an American Academy of Neurology article, we now have evidence-based guidelines that tell us that really patients with FSHD would be best managed by a multidisciplinary care approach. For some, that brings to mind seeing all your specialists in one center, and this is very common in the pediatric world, less common in the adult world. to see them all on the same day, but it still does mean that there are a variety of care specialists needed. What are some of these care specialists? And first up, I have the neuromuscular specialist, and I lump neurology and physiatrist together, and we're going to dive into that on the next slide. But your care team also involves physical therapy, occupational therapy, speech therapists, pulmonologists, ophthalmologists, cardiologists, audiology, pain management, and these just name the few. So for some of you, you might be seeing an orthopedic specialist, you might need an endocrine specialist. And these aren't to say that all of these are specialists that you continue to see. Sometimes you're screened for something and then you only need to be seen when symptoms arrive. So more of the core comes into the neuromuscular specialist, in addition to the PT and OT and speech therapists. So when we think about how does this work, what's the difference between neurology, rehab medicine, neuromuscular medicine? Who is it that I'm even seeing and who's taking care of me? So in just basic terms, before we dive into FSHD, a neurologist is someone that is thought of to diagnose and then provide some of the medical management for neurological conditions. So those can be anywhere from the CNS, so thinking of stroke patients, Parkinson's, MS, all the way down to peripheral nerve and muscle. FSHD. Rehab medicine is thought about as a physician that works to optimize function. They oversee therapy and orthotics. They do diagnosis of those functional limitations as well. And again, they also see patients from the stroke patients to the FSHD patients. Neuromuscular medicine is actually a subspecialty, and what's unique about this subspecialty is you can be a neurologist or a rehab medicine doctor that pursues this specialized training. It's a fellowship training, and it focuses very specifically on nerve and muscle. So neuromuscular medicines doctors are not seeing the strokes, the Parkinson's, the MS patients. They are seeing patients that have diseases that start at the level of anterior horn cells and then all the way to the muscles. So they're seeing the ALS patients to the neuropathy patients to the muscle disease patients, including FSHD. They're doing the diagnosis and symptom management, and they're also doing the mobility equipment and adaptive equipment. Now, here's where it gets a little challenging. To date, most neuromuscular specialists fall under neurologist, and that's how it's been for a long time. There have been more rehab medicine doctors that have become board trained in neuromuscular medicine, but there's certainly not as much as through neurology, and the training programs are through neurology. So I myself am a neurology, neuromuscular trained rehab medicine doctor. So I did my training in rehab medicine, and then I went on and did my fellowship in a neurology-based neuromuscular medicine fellowship. Now, the fellowship is what really hones us in neuromuscular medicine. That's not always available to everybody. So some patients will get their care through a neurologist, who may be more of a general neurologist and see many neurological conditions. It doesn't mean that they're not trained on FSHD. It just means that their focus is a little broader. Same with rehab medicine. Many rehab medicine doctors are general rehab providers. So they can look at you and examine your strength and your gait and make recommendations. But they may not know the specifics of FSHD. So they're going to examine what they see on you. In an ideal world, you would have partnership with both or have somebody well trained under neuromuscular that's familiar with both the neurology aspect of the disease as well as the rehab management of the disease. So hopefully I didn't make that too confusing there. So stepping away, again, it is helpful when you are rehab trained and you understand the diagnosis and management of FSHD, because then you can help with prognosis and help understand what may happen over the course of the disease. Our goals as rehab physicians are to evaluate the limitations in function, maximize function, and then limit any secondary complications before they happen. So, when we're looking at limitations in function, this is actually identifying those impairments. What muscles are weak? What muscles are in balance? So, where you have side to side asymmetry, or within one functional group, which muscles may be stronger or weaker? Where do you have areas where you can't fully range your joints? To maximize function, we are looking at, well, if we can't regrow areas that are weak, how do we still maintain independence? How do we use assistive devices correctly so that you are more independent? How do we reduce pain that is a function of that muscle imbalanced and restricted range of motion? And when are other modalities such as bracing appropriate? We know over time, if we have muscle weakness, that we're at risk for developing contractures, which is essentially when you lose complete range to a certain degree in one of your joints. We know we're at risk if we're in a wheelchair and we're not able to shift our weight around for skin breakdown. So we know things that can happen. What can we do to prevent them from happening in the first place? Again, going back to, yes, a rehab doctor is going to look at you in that moment and time. But here is where that specific neuromuscular medicine within rehab is very important, because your symptoms evolve over time. Unfortunately, FSHD is not what we call a monophasic event. It is not, a stroke that happens in one timeline, and then you're dealing with the repercussions. It is slowly progressive, more progressive for some than others. So we know early on what we're seeing is, oh, I got too excited there. We know early on we're thinking about our upper extremities. We're looking at what muscle weakness and imbalance do we have there. This is the time when some are considering the scapular stabilization surgery, which again is very rare and is very complicated and requires demonstrating that stabilizing the scapula on physical exam results in improvement in pain and function. This is the time when we're looking at how do we add low intensity aerobic activities and adaptive tools to compensate for the arm weakness. When we have imbalances in those shoulder muscles and neck muscles, that imbalance in muscle weakness causes pain or can contribute to pain. And we'll have pain discussions in a few slides. As the disease evolves and progresses, we start noticing that this is when we can start developing weakness in our trunk, our pelvis, and our lower legs. So now we're starting to think about lumbar supportive braces. This is different than what we think about in a patient without muscular dystrophy. A lot of patients are told, we don't want to brace because we don't want you losing muscle. And it's true. And, the goal is to engage our core muscles, make our paraspinal muscles stronger to reduce back pain. But when we have something like FSHD, where our paraspinal muscles are weak and our rectus and abdominal muscles are weak, then this is the point where this differs from other type of back pain. So we need stabilization. We need to add something to our muscles when we can't increase the strength of our muscles. And so using supportive braces. This is also the time when we start noticing weakness in the feet. So you might hear your foot slapping, you're off balance, you're tripping more, where we talk about ankle foot orthotics to improve your ambulation and to improve your safety from falls. Again, we're constantly talking about this low intensity aerobic exercise, which I will have a few slides on as well, and pain management. As the disease continues to evolve, one of the reassuring data points we have is that most individuals will maintain ambulation with assistive devices, but 20% do end up dependent on a wheelchair. And when that's the case, we need proper wheelchair evaluations to ensure proper positioning, especially when you're spending a long time in these wheelchairs. We need to make sure that the wheelchair seating is reducing risk of pressure injuries. We need to make sure that your positioning in the wheelchairs aren't contributing to contracture formations. We know that once we're in a sitting position, scoliosis can worsen. Our pelvic obliquity can change because now we're constantly in hip flexion. We also, as our disease progresses into the wheelchair dependence, is when we see more patients that have, just because it's a more aggressive form of the disease, respiratory involvement. And so we want to make sure that we're monitoring for that as well, and the ongoing theme of pain management. So, how do we interact with other disciplines? So, for physical therapy, we work with physical therapists to maximize mobility, keep you as functional as possible, regardless of whether that means that you're ambulatory or not ambulatory. Um, Using assistive devices such as canes and walkers, and making sure you're using them appropriately and that they're fitted for you. If you're in a wheelchair, making sure that we've given you an appropriate wheelchair, and that we've designed home exercise programs. We unfortunately know that adults with neuromuscular conditions, oftentimes their physicians don't know, when should I engage physical therapy if this is a progressive disease. They're not going to go, it's not that they had their hip replaced and then I'm going to send them to therapy to return to a normal baseline. Well, physical therapy is often introduced when there's changes in the level of function so that they can reevaluate what exercises you're doing at home and reintroduce new adaptive equipment. Occupational therapy. So, occupational therapists are the individuals that tend to focus on upper extremities, but more than just that. So, people see the word occupation and they think about it relating to returning to work. But in this sense, occupation refers to your activities of daily living, the things that you need to do as a human being to get through the day. So, how do you bathe? How do you eat? How do you transfer from one place to another place? And because a lot of that involves your arms and hands, they also focus a lot on that. So they can help with adaptations for overhead reaching, because we know that in FSHD, our strength in our shoulders and our range of motion there is significantly impacted. They can show how to appropriately stretch the shoulder girdle, how to provide assistive equipment for dressing, and how to make appropriate bathroom and shower modifications to both make you safe and independent. So maybe there are things that we can introduce so that you don't have to rely on a caregiver 24/7. When it comes to speech, this need kind of depends on each patient's presentation. So, speech therapists do more than just evaluate for articulation of words. They actually are very useful in helping us with swallow evaluations. And sometimes they work in combination with our radiologist to perform something called a video fluoroscopic swallow study, where we can actually see food that you are eating, coated in barium, and trace where it's going, how likely it is for you to aspirate. Are you silently aspirating already, or is there a risk for that? Um, it's not always cut and dry. So many people think, I don't want this study because either way, I'm not going to change what I'm eating. And that's always your right. But they can show you tricks, how to tuck your chin in when you're swallowing, to how to tilt your head to make sure that the food has its best chance of going down the right way. They can also make diet recommendations. So, would you do better with something that's a little thicker, because thin liquids tend to kind of rush down our throat and harder to control any sort of bolus in our mouth. Exercise is a common question that rehab physicians get asked about, especially in neuromuscular conditions like FSHD. the pendulum has swung in both extremes over the history of treatment. So at one point, many decades ago, the idea was don't do anything. And that led to a lot of deconditioning. And then it swung the other way, where it was like use it or lose it. And that also led to a lot of muscle loss. So the goal is to support low intensity aerobic activity. We know it's beneficial for chronic fatigue. We know that there has been some studies to show that it can improve strength in lower extremity muscles, as supported by clinical trials that show us that regular aerobic activity can improve fitness, can improve walking speed, and can improve overall health. What we want to avoid, though, is breaking down muscle because we don't know how well you'll rebuild that muscle. So we want to avoid activities that are causing muscles to be fatigued for more than 24 hours. Because, yes, there is a chance that you can rebuild those muscles, but there's also a chance that you may not be. And fatigue for more than 24 hours is really a sign that we're in that muscle breakdown zone. There have been studies to show that increasing from low intensity to moderate intensity, so not restrictive, still aerobic, has been shown to be relatively safe, but we haven't seen significant benefit in the studies over light aerobic activities. So it doesn't change how your muscle strength building, or in this particular study, it didn't change how long people could walk in 6 minutes or the time it took them to complete 5 sit to stands. When it comes to pain in FSHD, people used to think that neuromuscular diseases, because they originated in muscles and muscles don't officially have pain fibers, should be non-painful. And we know that is not the truth. So a majority of patients with FSHD report pain, 56 to more than 80%, with 19% reporting severe pain. In some cases, pain is their most limiting symptom. And then that circle of pain, atrophy, and functional impairment can become cyclical. So here is an FSHD patient and a study that looked at where are the most common areas of pain seen. So we see that shoulders and low back are the most common areas of pain. And these are notably the most weakest parts of individuals with FSHD. So muscle weakness means that those muscles can't generate enough force to kind of sustain our upright posture, to support our joints. Additionally, with FSHD, we know that the weakness can be asymmetric. So in other muscular dystrophies, they are much more symmetric. So you have side to side similarities. Those asymmetries can then cause additional pain because we're not sharing that load equally. So how is pain managed? And so rehab physicians also work on pain management. Sometimes we actually send you to another rehab physician known as a pain specialist. And pain specialists can be, anesthesia based or rehab based. And these individuals can help us with a more holistic approach. So combining things like PT, psychosocial interventions, and pharmacological treatment. Here we show what percentage of patients have received different pharmacological agents, the common being NSAIDs, which are like ibuprofen or Motrin, some that get opioids, some that get under the antidepressant class of family are medications like duloxetine or Effexor, which we know are now used in pain management for their chronic pain benefits. In terms of the non-pharmacological approach, physical therapy, acupuncture, massage, range of motion, biofeedback, these are some of the additional modalities that are introduced as well. Again, it's usually a combination approach. Unfortunately, sometimes our goal is not to make it 0 out of 10, but to make it much more bearable. and tolerable. And so stabilizing joints can sometimes be enough to help with shoulder pain. Sometimes it's a combination of stabilizing joints and medication. Sometimes it's a combination of stabilizing joints, medication, and then working with some cognitive behavioral feedback because we can't eliminate the source of pain. Now, we have noticed that there's no correlation between chronic pain and the age of onset or disease burden. So you can have what's considered mild FSHD and still have significant pain, or you can have severe FSHD and have no pain. Chronic pain, again, is not related to the genetic mutation. So you can have, a large fragment size or a small fragment size, and you can still have significant pain. So what we've learned is the best person who can describe their disease burden are you, the patients. And so looking at a study that was done taking about 1,000 individualized quotes from patients with FSHD, we realized that there are a lot of different symptoms that lead to poor quality of life, and different areas that we can be impactful on as rehab physicians. So, from fatigue and pain to social role limitations to, beyond just the functional impairments of arms and legs and trunks, but having to rely on caregivers. And so these are the things that our goal as rehab physicians are to address the tangible things that we can modify and then accommodate for the things that we can't necessarily fix. Moving forward, there are so many realms that we have to still explore. And I didn't put on this slide, the number one, looking for a cure, looking for a medication treatment. But still, we still don't have enough information on how can we use targeted exercises on which muscle groups to benefit patients, and how do we expand pain management strategies. So, we are still limited in the medication realm of what we find useful. We're still limited by the physical therapy because we can't just strengthen muscles to make them stronger to help avoid joint pain. And oftentimes surgery, our patients aren't surgical candidates given the weakness that could potentially affect recovery. So we still have a lot of areas that we hope to make progress on. I'm going to pause there. My goal or my hope today was to kind of give you an introduction into what different areas a rehab physician may be able to help with your FSHD, and to kind of explain rehab physicians' role in combination with other colleagues in addition to other physicians. So I'm going to pause there and I'm happy to answer questions.
So if anyone has any questions, please put them in the Q&A. But I did get some ahead of time, and I was kind of
Yeah,
monitoring them to see if you answered them, already. There are some very specific questions, and
yeah,
maybe we can address some of those.
perfect.
One, you mentioned wheelchair users can develop
Mhm.
contracture formation. Can you
Yes.
describe what that is?
Absolutely. I think that's a great question. So, what a contracture is when we develop weakness, it becomes hard to move a muscle. So, if this was your foot, and you could raise it up, so dorsiflexion, and you can raise it down to plantar flex, and you can make it invert or evert. If the muscles that do this start to become weaker, usually the muscles that go first are the ones that lift your ankle up, this dorsiflexion. So people start developing a foot drop where their foot is like prefers to be in this plantar flexion position. So over time, if we're not stretching that, so even though you can't bring it up all the way, if somebody isn't stretching to give you that full range. And oftentimes, if you're in a wheelchair, people, or you're not ambulatory, people can forget, well, I'm not going to be bearing weight on that foot, right? Well, over time, if you're not ranging it, the muscle will just stay in this position. A contracture means that then when somebody goes to evaluate it, they can't physically move it for you to that range. So you're essentially now stuck in that position. And the only quote unquote treatment would be surgery, but at that point, a surgical intervention for contractures is not always very easy once it's formed, and it is very vascular, and so there are risks for it reforming again. And so if you imagine, if you're stuck in this position and your wheelchair plate is like this, even that can cause a problem because now you can't get your foot down comfortably in the plate. More significant in knee and hip flexion. So if you imagine, if you're sitting, your knees are going to be flexed and your hips are going to be flexed. So if you're not ranging, so if you don't have, great strength to completely lift your leg up straight with your quads, and nobody's stretching you, you can start developing a contracture, so your knee will stay in flexion. And then if you can imagine trying to transfer to your bed with your knees stuck in flexion, you won't be able to lie it down straight. That will then contribute to pain. That kind of throws off the alignment in positions and can lead to back pain. So it becomes very cyclical. And so stretching is very, very important when we have weak muscles. Oftentimes people think of stretching when you have tight muscles, but it's just as important when you can't physically move your muscle to have somebody stretching it.
That totally led into another question that came
Yeah.
ahead of time was, can palliative rehabilitation techniques like stretching, breathing exercises, or pain relief modalities complement disease management? And you mentioned stretching. Could
Yeah.
you talk about some of those others?
Yeah, absolutely. And so I think 100%. So, in terms of, what becomes this palliative rehab, so palliative, I assume meaning that yes, we're not going to bring back muscle strength. So we're not focusing on the exercise aspect of it. But they should be a part of disease management because those are the things that are going to make sure that you don't develop secondary limitation. So we talked a little bit about the stretching and the importance for contractures, similarly to pain. So pain can limit function. If you're in pain, you're not going to want to do activities. You're not going to be able to reach even the amount that you can reach from your weakness. Your sleep's going to be affected. With poor sleep, then we now have your mood affected, and it becomes this cycle of um, potentially losing more function because you're not using the function. So on top of just the muscle loss from the disease. So we want to make sure that people's pain are managed as well.
Yeah.
And then I think there was another modality you mentioned, stretching, pain.
And breathing management,
Yeah, and
breathing
so breathing,
exercises even.
yep. So breathing exercises fall into a few different folds. So if you have evidence of diaphragm weakness, which can happen in FSHD, the therapy of choice is using a BiPAP. But in addition to BiPAP, there are ways of doing breathing exercises to kind of help with that diaphragm. Separately, maybe you don't have diaphragm weakness and you're referring to more breathing exercises as a tool that they use in cognitive behavioral therapy to reduce pain. So, different avenues for breathing exercises that can be helpful.
Excellent. Speaking of that, palliative,
Yeah.
what signs might actually indicate that it's maybe time to transition from that, to transition from rehab care to the more comfort focused palliative approaches, or vice versa, even?
Yeah, that's a great question. And so we think of palliative, or I think of palliative as adjunct, right? So you don't have to have one or the other. And a lot of times people think of palliative as end of life, which is not the case. So I think a lot of times people assume that they're going to palliative for hospice care. And Yes, palliative can help us with hospice care, but that's not always why we send people to palliative care. So sometimes people go to palliative care, and somebody once told me that palliative care used to be called narrative medicine, which I think is a beautiful term for it. So it is a history taking type medicine where they're talking through and trying to identify what are the most important goals for patients. How do you communicate these goals with your loved ones, even caregivers, and other parts of your medical team? And so, um, for example, if you if you're having swallowing difficulties and you may, the discussion of a feeding tube comes up in neuromuscular and other specialties, feeding tubes are often thought of as end of life. In neuromuscular diseases, feeding tubes are just a part of the tools in our toolboxes. So it is a way of managing this dysphagia, not necessarily end of life. And so palliative care can be really helpful in diving into somebody's belief systems about what type of care they're open to having and what type of care they're not open to having. I would say with a lot of FSHD management, a lot of those symptomatic care we do talk about in rehab medicine. So we usually go to palliative support when we really need to dive into these one or two issues beyond what time we've had. And so maybe, we've shared about, the choices and the risks and the benefits, but really you want to hone into, what is right for your belief in your quality of life. That can be really helpful. Palliative also can do pain management. And so I think it really depends on where you're located. At the University of Washington, we have a comprehensive pain clinic. So I tend to send my patients there before palliative, for pain management, but it really just depends on what's available in your area.
Great. Well, as usual, you went right into the next question that was on here is if I'm looking for a rehab specialist, experience in neuromuscular conditions, what's the best way to find one in my area? Like, what should I search for?
Yeah.
Yeah.
So I would say starting by looking at MDA centers of excellence is a really great first tool because most MDA centers of excellence have a neurologist and a rehab physician. And even if they're not neuromuscular trained rehab physicians, if they are in an MDA clinic setting, they have probably gathered that knowledge over time. Sorry, my screen went blank. They probably gather that knowledge over time and they are used to treating patients with other neuromuscular conditions in conjunction with a neurologist. And so they can also use the information from the neurologist on their team to help them with prognosis and expectations if they don't have that knowledge base themselves and apply that to the functional goal. So I would start with looking at MDA centers of excellence. And then for the providers that you do have, so if you are seeing a general neurologist, is there a neuromuscular neurologist? So part of neuromuscular training is there is a portion of that is focused on rehab. Obviously, not as much as doing a whole, specialty in it. But if you can't find a rehab, neuromuscular doctor, is there a neurologist that does neuromuscular that incorporates rehab? So some of them do over time, or asking them directly. So those neurologists often know their colleagues in different areas, that may have that subspecialty as well.
Yeah, that's excellent. I think that's one of the hardest times or hardest things about finding good care is just doing the research and finding somebody in your local.
Right. And
Right.
exactly. And I will say, we've already identified that um, neuromuscular trained rehab is harder to find. And so we at the University of Washington, treat multiple states in one location. And so you might end up finding something like that nearby where you're located as well, where there's going to be a little bit of travel and it might not be the physician that you see, every few months.
So take note, those of you in Pacific Northwest. You have an amazing team there. Take advantage of that. Um,
Yes.
I did have one question.
Yeah.
No, so my husband also has FSHD, and he was diagnosed, over 20 years ago. And were talking about exercise, and
Mhm.
decades, 20 years ago, the recommendation after diagnosis was don't do
Do
anything, don't
anything. Yeah.
exercise. And I'm so happy to hear that that has changed, that clinical trials,
Yeah.
studies have come out that says, yes, actually it is beneficial. But you had a statistic, and I hadn't heard
Yeah.
this before, um,
Yeah.
about the fatigue and when it goes from the exercise goes
Okay.
from being beneficial to not, and
Yeah.
had a statistic that how you could measure it
Oh,
internally.
yeah. So the word that we use for that is actually, and I apologize, I didn't put it on I was trying to keep it like not super wordy, but it's called delayed muscle onset soreness, DMOS. And so before we used to say don't do anything, and then it swung to do as much as you can. And then we realized we can't really tell people like uniformly to do this many sets of exercises per this time because everyone's disease is so different. But what we can tell them is if you're doing an activity and 24 hours later, so not just the next day, but a whole 24 hours later, you are so sore to the point that you kind of have to cut back your normal activity, then that exercise that you were doing was leading to muscle breakdown. And so, what I tell patients is if as somebody who doesn't have a muscular dystrophy, if I went to the gym and worked out to that point and, the next day couldn't, had trouble getting out of bed and doing things, I would relax a little bit. And then when I went back to the gym, my goal would be to rebuild muscle in a leaner form. The issue with muscular dystrophy is if we're constantly breaking down muscle to that point, we don't have a guarantee that we are going to rebuild it the next time we work out. And so the goal is, so if you find an activity, and usually we'd say, if it's the first time you're doing something, okay, you can, try it again. But if that consistently happens, then you either need to change the intensity or the duration of the exercise to get to the point where the soreness doesn't last a whole 24/7. So we now use symptoms to tell us, okay, this is when muscle breakdown is happening. We also counsel that if you can't move anything against gravity, and for layman's term, gravity can just be considered vertical. So if you were doing a biceps curl, going this way would be against gravity. Going this way would not be against gravity. So it's easier if someone holds your arm here to swing this way than to go this way. So if you can't move something completely full range, against gravity, then you should not be using weights on that. So weights are a form of muscle building and resistance, but if you don't have anti-gravity strength, we are not going to build muscle in that area, and now we're putting you at risk for damaging tendons and ligaments.
Ah, wow. That's excellent advice. Thank you.
Yeah.
Thanks to Renee Beaker, who put in the chat. We do
Yeah.
actually have a care connector tool on our website. And so those
Nice.
listening and after use this tool, we allow people to input, if they had a good experience with a local care provider, we allow people to add providers into the care connector if you've had a good experience or not,
Wonderful.
So thanks, Renee, for posting that. That's a
That's wonderful to hear. Yeah.
great resource for folks to have. So, um, and I will just ask one more time if there aren't any other questions. For Dr. Rod, we will wrap up for today. Unless you have any more last minute comments.
I just wanted to thank everybody for joining and trying to advocate for themselves. And so you really are your best advocators. If something doesn't feel right or you feel like it's not getting addressed, um, you know, your best team support, if we don't know the answer, we'll try to find it for you. And so um, you know your body's the best. We have the medical science to kind of put together your symptoms for you, but we don't know exactly what you're experiencing. So it's important to share it with us.
Absolutely. So awesome. Well, thank you everyone for joining us today. Special thank you to Dr. Rod for taking the time.
No, my pleasure.
Appreciate you so very much. Just a quick announcement. Our next FSHD University webinar is the topic is opportunities of strength training in FSHD. And it's Wednesday, August the 13th, same time, 11 a.m. Eastern. presented by Dr. Nicole Voet. She's a rehab physician and another physical therapist from the Dutch Center for Neuromuscular Disease. So have to put on our translation notes, translator. But we also encourage you to just take a look at our website. There's a calendar of events, both in-person events, virtual events like this one. So just please take a look at the website to see if anything really piques your interest. And again, thank you, Dr. Rod. You're amazing. And
Thank you.
we'll see you again, everyone, next month. So take care and stay safe and bye for now. Okay. Bye.
Bye.